CataractCoach.com. High-power IOLs for radial keratotomy. With extreme corneal flattening, that required IOL power is higher. So you can see the patients had prior 8-cut radial keratotomy. The patient was about a -6 diopter myope 30 years ago or 40 years ago and had radial keratotomy, which had a good effect and made the patient essentially plano for a couple of decades. And then about 10 years, 15 years ago, the patient started having a drift of more and more hyperopia. So RK, sometimes we say it's the gift that keeps on giving because it keeps flattening the cornea. Now, the initial flattening when that was first performed was very helpful in treating the myopia, but then as it progressed, it causes way too much flattening. So now starting off with a diamond, I'm kind of just measuring where can I sneak in my incision here. So we're going to sneak it in here. I'm not going to intersect those RK cuts, and I want to have a tunnel length that's good but not too long. And so we'll enter here, and we'll get the phaco done. And we're using a 2.2 millimeter diamond here, very slightly enlarging that. And that's fit very beautifully between the two RK cuts. Now, this patient did keep experiencing more and more hyperopia, and at the time of this surgery, the patient's like, 6 or 8 diopter hyperope. So the exact opposite. So in our calculations, we've determined that we want to put in a 33 diopter IOL, and that should let the patient end up pretty close to plano to minus a little bit. So we're getting that rhexis completed here. We want that 5 millimeter rhexis. Now, even though the IOL power is high, 33 diopters, well, of course, the AC is actually quite deep, very deep anterior chamber. Remember, this is an axial myope. While the K values are in the low 30 diopter range, the axial length is on the longer side, right? Probably 25, 26 millimeters or so. So plenty of room and working room in that anterior chamber. We're doing some hydro dissection here, a little hydro delineation as well. There's that nucleus slightly tilted up on its side, a little bit of viscoelastic here to protect that cornea. Do remember, these RK cuts are very deep, 90% depth or even more. So putting the phaco probe in there, using the pink sleeve, so it's a smaller phaco tip here. And now splitting that nucleus, chopping it in half, and you can remove each half pretty easily. You can aspirate those down. The nucleus removal is not the difficult part of this case. Do keep in mind that sometimes visualization can be impaired by the RK. So if you look at that cornea, you can see the distortion of the lights of the microscope. Plus, it's just not the best kind of red reflex, even though this is a patient with a light-colored iris and even a light-colored fundus, or posterior segment. And so take the cataract out, just careful not to puncture or damage the posterior capsule, get those few pieces out, chop her in the safe position, and that's removed pretty easily. Now time for cortex cleanup. Now 33 diopter lens is thick, right? Think about it. It's probably 1.5 times as thick as your standard IOL you're using for most patients, which is in the 20-ish or so diopter range. So you may have to enlarge the incision. And in fact, the lens says on it, it says, yes, you have to have a little bit bigger incision. And so you'll need to be very careful in enlarging this incision. Again, we don't want the phaco incision to intersect the RK cuts because that can cause them to rip open or leak. So there's really not a whole lot of enlarging we can do. We're going to have to do what's called a wound assist technique here. So putting in the viscoelastic, get our capsular bag nicely inflated. Also get the myopia, but I want a pressure of at least 10 millimeters of mercury here. I don't want the eye too soft. Now here comes the lens. And again, we're not going to be able to get the whole injector tip inside the eye. I will use the diamond to very slightly and cautiously, ever so slightly enlarge it. But I don't want to get too close to the RK cut. So that's about as much as I want to do. Now here comes the lens, and you'll see I won't be able to get the whole injector tip inside the eye. So we're going to use this wound assist technique. So I'll start to deliver the lens here. Injector tip is just abutted against the incision, and now the eye's getting out of primary, I know, but now we'll get the eye back to primary. I'm using an injector that requires 2 hands. So this lens was not available in the preloaded design, which I could inject with 1 hand. So I had to use 2 hands on the injector, the right hand to stabilize the injector tip, the left hand to twist and turn the plunger to deliver it. And there it is, delivered inside the eye, and that looks fantastic. Now also keep in mind, we need to be very cautious here. There's the 33 diopter lens. You can see it says use a B cartridge, B like boy. Normal IOLs are using a D cartridge, D like dog, so it's a big difference. So we'll go behind the eye, we'll remove viscoelastic. I'm definitely going to check all these phacoincisions at the end. So I'll check the phacoincision and the paracentesis, but also we're going to check all the RK cuts. At the end of the case here, once we get the eye to a physiologic pressure, we want to make sure that we're going to get 0 leaks anywhere. So we'll do a fluorescein leakage test for the entire cornea, the entire anterior chamber, anterior segment. Now keep in mind, even though we were very gentle during this phaco, it's a pretty brief surgery and minimally traumatic, we need to check the K values tomorrow. So again, slightly hydrating the incision. Notice the direction of the cannula towards the corneal apex. Do not hydrate the lateral walls of the incision. It's too close to the RK cuts. It'll damage and split open the RK cuts. You heard it here first. So in this patient, post-op day 1, the cornea is going to be even flatter than it was pre-op because those RK incisions swell a little bit. So what I want to do is see what the K value is on post-op day 1, and it'll probably be a little bit flatter by a diopter or 2 compared to the pre-op measurements. And then I'll follow the patient in the post-op period, and hopefully within about a month or so, the K values will go back to their pre-op K level. And then the patient will go from being a little hyperopic to being much closer to plano outcome. Here's the end of the case. A little triamcinolone inside the eye, small aliquot of moxifloxacin preserve-free. There's a little Wexel sponge soaked in tetracaine. Let's get out that fluorescein dye. We're going to use that dye and paint the whole cornea. So here's a sterile fluorescein strip, painting the entire cornea. Check all the RK cuts, check the main incision, check the paracentesis. All looks good. Poke on the eye a little bit, make sure nothing's going to leak. And we're happy. So beautiful outcome. Happy to say the patient was thrilled with the new vision. Wash off the fluorescein, and hey, let's call this one a day. Thanks for watching.